Sean Secord, Sean standing at the back there, I'm sure you've seen him already, is Vice President of Clinical Engagement at Nanostics Incorporated, a name which might sound familiar to you because it was about a year ago when Dr. Desmond Pink was here, along with Dr. Argo Basu of Nanostics, and they shared their groundbreaking work in prostate cancer screening and led them to the creation of a new prostate PSA test called ClarityDX Prostate. Since then, amongst the many other conferences, you might have seen Sean and Desmond out about the province setting up their ClarityDX tent at various Ride for Dad events. And I met Sean recently in Coaldale when we were doing some PSA testing down there. It was a very busy summer for Sean and his team, and so we're very pleased that he's able to join us tonight and give us an update on ClarityDX Prostate. So please join me in welcoming Sean Secord.
This is a long title because I gave a presentation to nurse practitioners across the country, and this fit with their theme. So, embracing technological advances to align with new and emerging guidelines in cancer screening at the primary care level. Or in a nutshell, prostate cancer screening in 2024. There we go. So this is a little bit about me. Mostly just to tell you who's up here in front of you. I went to Western in London, Ontario, coincidentally at the same time as John Lewis, our CEO, and Colin Koros, our Chief Commercialization Officer. We didn't really know each other at the time, although I'm sure we hung out at the bar on campus together. They were busy becoming researchers. I was becoming a clinician. I did a degree in biology and then a degree in nursing, and I worked at London Health Sciences Center in transplant and intensive care. I moved to the Yukon where I helped establish a medevac service and open up 2 new rural hospitals, and then I ended up getting degrees at these places while I expanded my realm across the country. So as a nurse practitioner working in 3 different provinces in all 3 territories, the clinical aspect of cancer screening is very real to me. I know that from the clinical side. And so Nanostics is made up of 13 people basically who work there. And all of us have a great background, that we all bring our experience to what we do and the passion. And I'm very excited to be part of this team. How it all started, Frank Zajonki was a businessman. He was from Regina, Saskatchewan. An entrepreneur, got involved in a lot of things. I guess everything from sales to golf courses to overseas accounts, and became very successful. And eventually he moved west. He was living in Edmonton in the 90s when he started to deal with prostate cancer. And he had to travel back and forth between Edmonton and Vancouver to get his prostate cancer investigated, dealt with. And at the time, being a very inquisitive man, he's asking about, well, where's the research? And what are the new things, like what's on the cutting edge? And told time and time again, well, there's not a lot of research and not a lot of energy that goes into prostate cancer. Being a very motivated guy dealing with the diagnosis himself, he gathered a few friends who were successful business people and formed the Cure Cancer Foundation, which eventually became part of the Alberta Cancer Foundation. Somewhere between $15 and $20 million to start with, and then they hired John Lewis from University of Western Ontario in London to come west and develop Lewis Labs at the University of Alberta. And one of the first things that came out of that was the Alberta Prostate Cancer Research Initiative. So Alberta was the perfect ground for having, one health authority, 2 major centers, several urologists, a lot of men dealing with prostate cancer, such that the Alberta Prostate Cancer Research Initiative elicited consent from many men to donate fluids, blood, urine, semen, towards what has become the biggest biobank dedicated to prostate cancer in the world. So since 2012, that biobank and those researchers have delved into innovative areas, looked at new ways to research, and because Frank Zajonki said, I want a better test. And that was sort of the mandate of Apkari and Lewis Labs. And so for the last 10 plus years, that's been what they've slaved at, to try to get a better test for prostate cancer. Why? And you guys know this more than most. Prostate cancer is very common. About 28,000 men in Canada this year will be diagnosed with prostate cancer. You've seen these numbers on posters. You know how real this is. 5,000 men will die in Canada this year because of it. And so it's a real public health concern and something worthy of a lot of research and investment and awareness. That's been, I mean, Dave was talking about, the controversy right now with these urologists say this and these urologists say that, and it's because we didn't have the attention that we need. And now that a lot more attention is being focused this way, these guidelines will be smoothed out and streamlined, and we'll get the evidence-based approach that we need. At least that's what I believe. Prostate cancer, when it's found early, when it's still in the prostate, is very treatable. The 5-year survival rate for local prostate cancer is close to 100%, basically curable when you catch it early. However, if the cancer is allowed to spread to surrounding tissues or metastasize throughout the body, that survival rate drops very quickly to closer to 30%. So the need to screen is real. And this is one of the things, when you're coming up against people that aren't informed or have heard different messages, well, why? I mean, if they're asymptomatic, why are you screening? This is why. Because you catch it early, you can make a difference. In fact, in 1986, it was discovered that you could detect prostate-specific antigen in the blood when something's going on with the prostate. Now that's the thing, it's when something's going on with the prostate. PSA leaks from the prostate into the blood when the prostate is irritated. And 80% of the time it's irritated for something other than clinically significant prostate cancer. However, 20% of the time it is prostate cancer. And it's it's a simple blood test, right? You guys, I'm preaching to the choir, I know. But in the 90s, when we started to use it for screening, you can see the mortality rate due to prostate cancer was dropping between 3 and 4% per year, year over year. It was very effective. This is a retroactive meta-analysis done in 2023 where these researchers looked at different screening modalities for different cancers. It's a little bit difficult to compare one cancer to another, but basically they said there is lifetime gained and lifetime lost when you're screening for anything. I mean, the lifetime lost is sometimes the anxiety, the stress, the interventions, the time off work. Sometimes it's actually risk, like exposure to radiation. But the lifetime gained is catching those cancers early. So when they compared lifetime gained versus lifetime lost using different modalities to screen for different kinds of cancer, you can see on average, using PSA for screening for prostate cancer results in more lifetime gained than lifetime lost. And better than some other cancers that tend to get a little bit more of the limelight and more of the attention. Again, it's somewhat controversial because you're comparing one cancer to another. It's a little bit apples and oranges. But the point is that screening is effective. So why then, if catching it early is so good and the lifetime gained has been proven, is it not more strongly recommended or has not been in the past? And again, I'm preaching to the choir here. Because when your PSA is up, in the past, the only way to definitively figure out is it prostate cancer, is it clinically significant prostate cancer or not, is to go through the rectum with about a dozen needles into the prostate. And not only are you going to a round object from one direction, so you can miss places, but you're also interfering with an organ, which is a secondary sexual organ, that is right there beside the bladder doing all kinds of important things with the bladder. So that means the biopsy itself runs the risk of erectile dysfunction as a consequence, incontinence as a consequence, and the rectum, of course, the bowel is a very bacterial-rich environment. Going through the wall there with needles runs the risk of infection. And that's to find out if you have prostate cancer, which means a lot of the time you have this procedure to find out you don't, and then you're dealing with the consequences. So this is a necessary thing for diagnosing prostate cancer, but what we want to do is preserve it for those that really need it. Unfortunately, there were a couple task forces in Canada and in the States. The U.S. Task Force for Preventative Health in 2012 recommended against using PSA for screening because of that exposing a lot of men to invasive procedures that didn't need it. There was an overcorrection, and the U.S. realized that. By 2018, they rescinded that, and they're in the midst of updating it again. Canada followed U.S.'s lead in 2014, making a recommendation against it, and they tell me that they're going to update it in 2026. based on studies they stopped looking at in 2022. So it hurts my patriotic belief in Canada when I see the States doing so much better at some of these things, like so much more advanced and progressive and logical. But hopefully we get there soon. This is actually the U.S. Preventative Task Force's approach. And there's a lot of words and they're very small on the slide. But basically this is asymptomatic men and screening with PSA and what kind of steps should we do. So all of these numbers are different investigations they're doing as to what does the evidence say. And number 4 right here is, should we be using risk scores, biomarkers, other adjunctive tests to screen for prostate cancer? Which ones are more effective and what difference do they make? And I've been dealing with this organization to get ClarityDX Prostate on the radar. It is quite possible that in the coming months to years, their recommendation will actually be for ClarityDX Prostate. The reason that the task force in the States definitely changed their mind, and hopefully Canada does soon, is, when I said when you catch prostate cancer early, when it's localized, it's very easily treatable. It's curable. However, after the recommendations in the years that followed, the incidence of catching that prostate cancer early steadily decreased, whereas the incidence of catching it when it's spread to surrounding tissue and actually metastasized throughout the body increased. So this is real measurable harm caused by recommending against screening for prostate cancer. The Canadian Urology Association updated their guidelines. We're still waiting for a national Canadian, the Canadian Preventative Task Force. However, other entities like the Canadian Urology Association have made recommendations that by age 50, Dave talked about the pros and cons about 40, and it's true, but their recommendation for now is by age 50, most men should be screening for prostate cancer with PSA. That should be starting at 45 if you have a family history. If you have a brother or a father that has prostate cancer, your risk is 5 times greater. If it's a second degree relative, an uncle or a grandfather, that's twice as great, or twice as much of a risk. Regardless, if there's a family history, you want to be starting by mid-40s, and this is by this age. So like Dave was saying, he can name a few people in their 40s that are dealing with prostate cancer. And part of the reason not to screen is to not expose them to invasive tests. But if we have a new screening modality who can figure out who actually needs a biopsy and who doesn't, that fear and uncertainty and that reason not to screen is taken care of. So what the Canadian Urology Association recommends is, if your PSA is over 3, consider adjunctive testing strategies, which is what we've been developing here in Alberta. The ideal approach to prostate cancer screening, as I've sort of alluded to, is you want to preserve the mortality benefits of catching cancer early, but reduce the overdiagnosis and overtreatment and harmful aspects that come with just blindly biopsying more people than need it. ClarityDX was developed, like I say, between 2012 and about 2018-19, and then validated in a study that I'll show you in a second, and published this June in a journal called Nature Digital Medicine. This is the journal here, the article that was published. Using ClarityDX Prostate is 3 to 4 times more accurate than PSA by itself. Reduces healthcare costs, was based on real-world evidence, prioritizes those that need biopsies from those that are good with watchful waiting, and was made available to people in Alberta last September 28th. As of June this year, through a partnership with another lab, was made available in BC, Ontario, Saskatchewan, and through another lab in Quebec and through the territorial lab in the Yukon. We've done one study in the Yukon, which I'm very happy about because that was where my passion for this started. As of a few weeks ago, we partnered with a company to avail it to Florida, and very soon it'll be available in the Middle East. Now, this is good because the more men that get this, the more lives that are saved. Again, my patriotic pride has hurt a little bit that we can get to the Middle East before we can get to New Brunswick. The validation study involved 5 sites: University of Alberta, University of Calgary, UCLA, Johns Hopkins in Baltimore, as well as Tamar University in Prague. So 3,500 men were involved in this validation study. This is like a significant, again, when you're dealing with physicians or people that aren't maybe up to speed on things, and they say, well, what's it based on? It's based on a lot. 3 countries, 5 institutions, 3,500 men. And since then, because we've applied for FDA approval in the States, the U.S. Federal Drug Administration would like to see more African American, Latin American, and Caribbean men in the study. So we've partnered with some labs in Florida and the southern states to utilize their data to extend this beyond the 3,500, which will help make it more applicable to more people, but also make it that much stronger. What ClarityDX Prostate does is it looks again for PSA. PSA, like I say, it's released from the prostate when the prostate is irritated. The test that everybody gets is just a total PSA. The PSA that is actually bound to protein is more associated with prostate cancer. So we look not just for the total PSA, but for the percentage which is free, and therefore by by subtraction, the percentage which is bound to protein, and the ratio of those two things to each other. And then you feed the machine learning algorithm clinical data, the patient's age, whether they've had a previous biopsy before that was negative, if you know it, whether their digital rectal exam has nodules, whether it's normal or abnormal. And this is all at the primary care level. Urologists also appreciate this because when they have more information, like the volume of the prostate and the PIRAD score, this is the what the MRI measures. These 5 things fed into the machine learning algorithm, while it looks for these, produces a result that's about as accurate as a biopsy, and it's non-invasive. I mentioned the study that was published in June in Nature Digital Medicine. That involved all of the men in that study. We looked at their age, whether they had a biopsy before or not, and their DRE results. Once that was published and we talked to different primary care providers and urologists, they're like, well, we don't always have DRE results. We want to be able to utilize your test without the DRE. So we went back and studied ClarityDX without the DRE and the area under the curve. So this is sensitivity and this is specificity, meaning how easily it picks up the problem and how specific it is to prostate cancer. If it was perfect in both directions, you'd have a number of 1. You can see PSA by itself has a number of 0.63, not very close to this top corner. When you use the information that has the age and whether they've had a previous biopsy or not, you get 0.80. If you add the DRE results, 0.82. So it adds about 2% accuracy to the big picture. And like I say, if we get into MRI results and DRE and MRI, we're up to 0.87. Very close to this top corner, very specific and sensitive, which is what we want. So this is the care pathway that I mentioned before about the Canadian Urology Association, where they say, and this is what Dave was talking about, is it 50 to 70, is it 40 to 80? 50 to 70 is sort of what's written down in textbooks. However, there are outliers and that conversation encouraging, if you can take the risk out of it, why wouldn't you start at 40? And the idea at 70 is kind of ageist because, well, do they have more than 10 years left to live? I can tell you a lot of 70-year-olds that would slap me if I told them you don't have more than 10 years left to live. So getting up into the 80s makes a lot of sense, right? But, written down by the CUA in 2022 is 50 to 70. So if your PSA is less than 1, screen every 4 years or so. Keep screening, but it doesn't have to be every year. If it's 1 to 3 every 2 years, if it's over 3, consider adjunctive testing, which is ClarityDX Prostate. And by utilizing this at this stage, you're going to save between 32 and 47, so about a third to a half of biopsies. So you're not exposing people to invasive procedures that don't need it, but you're also prioritizing those that are high risk. This is basically just the same pathway, but just that bottom line where we've got ClarityDX in here. So you can say, if this shows you, if you've got an elevated PSA, if it's over 3, let's say a 3.5, and so you do ClarityDX and you find out it's low risk, then you can reassure this person that they probably don't need a biopsy, they don't need to be like first in line for urology. Watchful waiting is a good approach. However, if they find out that they have an 87% risk of prostate cancer, this is the person you want to put to the front of the line because they're going to benefit by that early screening and the early intervention. So these are four examples, legitimate examples of what a ClarityDX report looks like. This is like that first example I just told you about a person who had a PSA, and it's very small. I'm sure you can't read that, but I can tell you that every one of these has a total PSA of 3.5. So, I mean, in a primary care provider's office, you have a PSA of 3.5. What do we do with that? Are you high risk, low risk? And in the past, they kind of looked at other things, like, well, what was it last time? What was your baseline? Baseline really doesn't matter when it comes to the prostate. I mean, it could be irritated one day and not irritated the next. It's not a steady curve. They're individual, mutually exclusive events. So adding ClarityDX prostate and looking at the 3 PSA and their age and other clinical features tells us that this person is very low risk. Doesn't have to wait in line. Watchful waiting is a good approach. However, these people, with their free PSA, and then these two also including MRI and DRA data, you can see that they should be expedited to the front of the line. So that, in a nutshell, is what ClarityDX is. It was developed here in Alberta. We are working right now with the Alberta government on a clinical utility study because, I mean, to avail this to the most amount of people is to have the health system pay for it, right? It's so much easier if you can check off a rec, they go get it, there's no money exchanged, the results go to your primary care provider. However, talking to Alberta Health, they're like, well, we've in the past have said, oh, yes to something and find out that it actually doesn't improve health outcomes, and then we can't afford to fund everything. So we're in the midst of doing a clinical utility study over the next year or so where we can actually measure how much in the way of healthcare spending is saved and add a number to the better clinical outcomes. So when we get there in Alberta, Alberta Health will pay for it. We've applied to BC to their benefits program, and they're doing a health technology assessment in BC. We're asking the different provinces, like, what do you need? How do we satisfy your need to add this to what's covered? And of course, we have 15 different health systems in Canada, and so everyone is different. So it's a bit of a barrier right now. We're pretty sure, based on the preliminary data, based on the data that's coming in, based on the feedback, this will become standard of care, hopefully within the next 3 to 5 years. However, in the next 3 to 5 years, there's a lot of men that could benefit from this test that may not be able to get it because of the financial aspect, because sometimes there's different barriers to adoption. One of the reasons I'm here, one of the reasons that Des was here last year in Argo, and why we went to the Ride for Dad events, why we hang out at a tent beside the man van, is that patients, providers, and the health system all need to know that this is an option now. We need to get it integrated into guidelines, which are very complex. I mentioned about how we have 15 different health systems. There's 13 provinces and territories. Then federally, there's the veterans, RCMP, and incarcerated people, as well as non-insured health benefits for the Indigenous population. So that's 15 different systems that we need to work our way into the guidelines, which we need awareness, we need lobbying efforts. I was glad to hear Dave say that earlier. And then, like I say, cost coverage. There's a perception that if it's not covered, then obviously it must not be important. But no, it's just we haven't got there yet. Can it become part of benefits? We're working with the Edmonton Firefighters Group that when they do screening, firefighters are actually at a greater risk for about 21 different cancers. Lung cancer is obvious, prostate cancer is one of them as well, predominantly male population. So getting ClarityDX into their benefits package. And then it's much more seamless, of course, if we can get it part of every system's guidelines and processes. So I was meeting with Dave and Brad a few months ago, and they said, well, if we're fundraising, what can we fundraise towards? A lot of our research is well underway. What makes the biggest benefit? And we came up with an idea of a fund called Clarity Assist. So Clarity Assist would possibly, and this is a proposal, up there, that this might be an idea that maybe prostate wants to get involved in or possibly lead, where you raise money towards a fund that will avail ClarityDX to those that need it. Those that maybe can't afford it financially, or maybe we give vouchers out to healthcare professionals, vouchers out to primary care networks, and say, here's a dozen tests that are paid for in this fund. Give them to whoever you think is most at need. So this could give a direction for fundraising, overcome the financial barrier, like I say, accessed individually or by the healthcare providers. And we know already from the feedback and from the research, this will save lives, save costs to our healthcare system, prioritize high-risk cases, and save those that don't need it from invasive procedures. Yep.
Just while you're mentioning that, what is the cost? If I walked into your office and said,
Yep.
I need ClarityDX, I got my checkbook,
Yep.
what kind of number?
$300 here in Alberta. So $300 covers the cost of the test. And APL, Alberta Precision Labs, anywhere in the province will draw that blood. It's just 2 serum vials, spin it, freeze it, send it to Edmonton where we do the test. We partnered with different companies across the country. So Life Labs and a few others we're working with in BC, Saskatchewan, and Ontario will draw the blood, freeze it, and then ship it. But of course, that adds that component because they've got to get it to Edmonton. So unfortunately, in the other provinces, it's $500. And that, like I say, is just covering the cost of the test. Hopefully, and I mean, like I said, in the Yukon, one of the reasons that we really liked this idea is that a medevac down to Vancouver to see a urologist is anywhere between $3,000 to $10,000. So paying $300 for a blood test, even $500 for a blood test, is an easy, return on investment. Of course, again, we have different budgets, and you have the silos, and you're trying to overcome some of those issues. But like I say, I think that in Canada, the benefits of this so outweigh any problems that this will be standard of care at some point soon. John.
When you do this and feed the PSA test into your algorithm, you also have to have our medical professionals, like our doctors, give you some of the other data that they have collected over the.
So it's a prescribed test. So you go to your healthcare provider, be it a family physician, nurse practitioner. In Alberta, pharmacists could order this. But I think we have primary healthcare teams, but any primary healthcare provider is going to have the conversation about you're at an age where we want to screen for cancers. We catch them early, easily treatable, and so I have that discussion and then prescribe it. And then on the rec, they'd fill out, obviously age is going to be there for anybody on a rec, but whether you had a biopsy before or not. And then if the doc has done a digital rectal exam, can say whether that was abnormal or normal. And then the patient pays for it, or if we have a Clarity Assist fund, it's covered, and then they go to the lab with that. And so then that data makes it to the lab where we measure the PSA, the free PSA, put the clinical features into the computer where the algorithm is running, and give you your report. So I'll answer questions, but one thing that that Brad and Dave and I were talking about was, I can rhyme this off basically in my sleep now because I've given this sort of presentation several times. But I know even my brother this morning talked about how he's back in Ontario. He goes, I just got back from the doctors. He doesn't think the PSAs are good ideas. And I'm like, he goes, they don't measure cancer. I said, of course not. I never said they did. They measure irritability, but 20% of the time that irritability is due to cancer, which is a pretty good number. So we made up these business cards, which are a little bit small. The next rendition of these are going to have bigger font. But it just says under a couple points what ClarityDX is. And on the back is a QR code. When you scan it, it goes to our website. So Dave and Brad had said if we had these handy, then you could just have them in your pocket and somebody says, well, what's ClarityDX? Say, here it is. Well, I want to tell my doc about it. Show them this, have them look it up. So this is going to help with the awareness piece. And more than happy to answer any questions. Yes, sir.
And I want to know how long does it take to get the results?
About 24 hours here in Alberta. In the other provinces, they're often pooling them. So, they might, draw blood on Monday and Tuesday and then send it on Thursday. And so it's once we get it, if we got it on Thursday, then you get the results on Friday. So in other provinces, it's going to be like 3 to 5 business days. But here in Alberta, well, you'll have that result within 24 hours. Yes, sir.
And you did all this without the benefits of AI?
Can you do it without AI?
No, so you did all this without the benefits of AI?
We utilize AI. The machine learning algorithm is artificial intelligence. Okay. So that is a predictive tool, which looks for risk factors and sends the data down different pathways. But yes, I know what you're saying, that there's an idea that artificial intelligence is the last thing that humans will create because everything else in the future will be created by artificial intelligence.
That's scary.
A little bit. But as long as, I mean, it's like any other tool. As long as you understand it, embrace it, and use it to your benefit, it's an asset. Nothing to be afraid of. There are so many things that would benefit from an artificial intelligence that is just sort of gathering data and pointing out some things that may be missed by humans. We all get tired. Other questions? Yes, sir.
So you're saying like you can get a clarity based on if I've had rectal ultrasound or anything, or can I just go and my doctor sits there and says you can go for a PSA test? Said no, I want to spend $200. Can I just go get a clarity?
Soon. Now, because the way this was validated, it was validated as a reflex test. Okay. So ClarityDX prostate, by our studies and our development and our validation, is to be used when your PSA is over 3.5. So at this point in time, you need the PSA first, because the negative predictive value. If, like I say, if a prostate is irritated, it's going to put prostate-specific antigen out of the blood, and when you do a blood test, you're going to measure it. If you do a blood test and you don't measure any PSA, the prostate isn't irritated. No cancer, no nothing. So the negative predictive value is good. So PSA is a good screening tool for the negative side. It's when you get to the positive side that you want to say, well, why is it elevated? I need more information. So ClarityDX is good as that second test. Now, in Alberta, in a lot of places, urologists don't want to see you unless you've had 2 PSAs. So that second PSA could and should be ClarityDX prostate because it gives you much more information. In the future, the way that we see this working is that you'll go in your screening, you'll get your blood drawn, they'll run the PSA. If it's elevated, they'll run ClarityDX automatically. Like once this is part of what's paid for in healthcare, it would make sense for them to run that at that time. And then you have the full answer from one blood test. But that's sort of the future state. Yes?
Okay. Does that mean when we do the clarity test, we get 2 results, 2 different results back, the total PSA and the free PSA?
Yes. I mean, the slide was tiny, but all of the details are there. So at the bottom, it'll give you your PSA, your total PSA, and the normal range. It'll give you your free PSA and the normal range, as well as the risk score.
Which one is the most reliable?
The risk score.
Is it a free?
Because a PSA on its own has a specificity of 12%. A free PSA on its own has a specificity of 11%. The secret sauce is the machine learning algorithm that's going to look at the ratio of those two things to each other in conjunction with your clinical data, your age, whether you've had a biopsy before or not. So it's that machine learning algorithm that combines the ratio of the 2 biomarkers, your clinical data, that now gives you a result that's 36% accurate or 47% accurate as opposed to 11 or 12. So I know as physicians are often like, well, I'll just measure this and I'll look at the chart and say, what is it? But the free PSA and the total PSA on their own are not very accurate. It's the 2 of them together, clinical features, machine learning algorithm. Anytime.
Any other questions?
So I understand that the Clarity Diagnostic TX prostate stands as an intermediate test between the normal PSA and the biopsy, right? So whenever the PSA is high, instead of going directly to the biopsy, we can do the Clarity test to see whether to go to the biopsy or to wait for some time before.
Absolutely.
Okay, thank you.
That is, yeah. In a nutshell, that's, yeah. Awesome. Other questions?
Can you repeat that last question, please?
Yes, it was just reiterating that ClarityDX prostate is the step you want to use after doing your initial PSA, finding out that it's over 3, so you're running ClarityDX to see if that elevated PSA is a result of some sort of benign irritation or has a greater risk of prostate cancer. And in the latter case, you're going to go for a biopsy or talk to your urologist about a biopsy. In the former case, at this point, you'll still be talking to your urologist and your family physician, but the watchful waiting is the best approach at that point.
Great, thank you.
You're very welcome. Any other questions online? Totally forgot about the online people. I did get the look every time I wandered away from the camera. So I did know you were there. Thank you for joining online.
I'll ask you a question, if I might.
Please.
Would the ideal situation for the future be for your organization to work a lot closer with an organization such as the Prostate Cancer Center and the Manvan people? In other words, could they be drawing enough blood for both tests to be done?
This is going to be super tiny, but Eric Heinemann, these are the authors of the study that was published in June in Nature Digital Medicine. Eric Heinemann is a urologist at the Prostate Cancer Center. Adam Kennard is a urologist in Edmonton. Adam Ferry is a urologist in Edmonton. Chris Wallace is here somewhere. He is a urologist. There he is. He is a urologist in Toronto. So both APCARI and the studies that were done to go lead to this test had the input of about a half a dozen different urologists. In fact, at the time when they were doing the validation and the development, they viewed this as a tool for urologists to know who to biopsy and who not to. And then realized, as you do, as you go on with the research, that this is a fantastic tool at the primary care level. We should be using this with nurse practitioners and physicians in primary care so that they know who needs to see a urologist versus who maybe doesn't need to see a urologist right away. So the urologists were involved. With anything new, it takes time. People have to change habits. There's awareness. So yes, we need to work hand in hand. And like Dave had mentioned off the start, some of the urologists in Edmonton do things different than the urologists in Calgary. And we're seeing that again in BC, Saskatchewan, Ontario, and the different cities. So little by little, with the evidence and the conversations and the collaboration, hopefully we'll all be on the same page at some point soon.
Thank you.
You're very welcome.
Sean, thank you. Most enlightening indeed.
You're very welcome.
I guess that